like to welcome everybody out. For any of you who don't know me, my name is Dr. David Porter. I own Synergy Dental Center in Gillette, Wyoming, and Sturgis, South Dakota. So welcome out. One thing that is really close and dear and near to my heart is growth and development. This is a subject that is widely misunderstood or really completely the education of it is just completely missing in dental school or medical school. So it has taken me a number of years to accumulate information and knowledge through really thousands of hours of continuing education, lots of different books. And so I'm here to share this with you just because, as I said before, I'm very passionate about it. And it is something that can be um, a lot of what you're going to see here is things that go good, just either completely unnoticed or completely undiagnosed. So in America, we see this epidemic of people that have sleep apnea. It's just becoming really the norm in our modern society, and so all this is due to an inadequate airway development. And certainly, this starts very early at birth. It has very little due to genetics, as we can tell, just because we've seen the trend just increase so much over the years. When we see crooked teeth, or our children need braces, or something like that, that is a sign of that we are developing in a way that is not up to our genetic potential. So everything that we're going to share here tonight is for the goal of developing to the genetic potential. Every person has the genetic potential to never have braces. Okay, so we have to start with that. Braces are not necessarily a terrible thing all the time, and we'll get into that. But braces are a sign of a bigger problem, inadequate facial growth and development. So, again, my name is Dr. David Porter. I own Synergy Dental Center. Welcome to everybody tonight. So, I have to start off with, my family, which is obviously near and dear to my heart. They've supported me through all the thousands of hours of continuing education that I've been on, that is required to me to be on weekends and weeks upon end, and so I've had their support the whole time, and that's really what's made this possible. So I certainly love them and appreciate them very much. So I have to plug my book here just a little bit. I wrote a book that was released last year. It was an Amazon bestseller, and it was really going into a part of what we're going to be going over tonight, which is airway inside the title of the book, Airway Infections and Metals. We'll go over a little bit of biologic dentistry this evening as well too, but really the focus is on airway. And so that's my book. You can purchase that on Amazon if you'd like. So another fantastic book, I'll go over just a couple quick books here that I think are just very great, that you can read yourself. This is another good book written by a couple colleagues of mine, Dr. Gelb and Dr. Hinden. It really kind of goes into the science of airway health and talks about, when the airway doesn't develop well enough, the we can get things like brain damage. The brain does not develop the way that it should or the way that we need it to. And so of course, I won't be the spoiler here for the book, but very good book. Another very good book here is written by a colleague of mine, Patrick McEwen. He's really a breathing expert, is the best way to describe him. He's written a book, The Oxygen Advantage, and one very neat book here is called Close Your Mouth. Very simple, about lips together, breathing through the nose, tongue to the roof of the mouth, which is the foundation of facial and airway development. Baby-Led Weaning is also a very good book as well too, talking about the right way, the ideal way to start facial growth and development as a baby is growing and developing, which obviously is the best time to do that. Okay, so our health. Ideal health and wellness and brain development are dependent on an open airway, nasal breathing, and deep restorative sleep. So obviously here, oxygen is the key. Correct oral posture is the foundation of our health. So to have correct oral posture, the tongue has to be up to the roof of the mouth. We have to have nasal breathing, and our lips have got to be closed. Okay, those are the three pillars of correct oral posture. Okay, when we have correct nasal breathing, tongue to the roof of the mouth, and the air and the lips are closed, the jaws develop forward. Okay. The tongue resting on the roof of the mouth is going to develop the maxilla, the mandible is going to follow, and we get a more attractive, certainly look, which we'll see here later. But more importantly than even that, we get a proper airway that's developed. Okay. With a larger airway, we can breathe easier. The easier we breathe, the healthier that we will be. So, facial development is really dependent on the maxilla. So, the maxilla is the bone up here. The top bone is the maxilla. The bottom one is the mandible. As I was saying earlier, the tongue should always be resting in the maxilla, okay? 100% of the time. As soon as our mouth comes open, the tongue is going to drop, okay? So, that's why we preach nasal breathing, lip competence, meaning the lips have got to be together. Okay, the most important bone in facial development is the maxilla here. The most important muscle in facial development, obviously, is the tongue, which supports the maxilla and drives the maxilla forward. The tongue is what develops that maxilla. So this is the most important thing. Okay. This is a look at ancestral face to modern face. If you can look at the modern face over on the right-hand side, you're going to see a face that is really very long. Okay, this is normal nowadays, obviously. Very long and very slender. Okay, now, obviously, Michael Phelps is an Olympic champion 20 times over. But certainly, what goes through my mind all the time when he was, winning all these gold medals of like, wow, how amazing he could have been if his airway would have supported, if his airway was larger. Okay. And it certainly could have been based off of just the shape of his face. When the face elongates like that, the airway always is going to be smaller. When the jaws develop forward properly, okay, the airway is always going to be larger, okay? So we can see an ancestral face over here on the left and a very modern face over here on the right, okay? Now, certainly if you go to poorer countries, okay, maybe like Africa or places in South America, you're going to generally see faces still that are on the left-hand side, and that's just because very little has changed in their world. And a lot of things have changed in our world, especially since the Industrial Revolution. Okay, so again, these are primitive dental arches. Okay, these are arches where you have all of your wisdom teeth. Okay, all 32 teeth in your mouth, and you typically have space behind your wisdom teeth. What we see here in modern, certainly westernized culture, is nobody or very rarely do people have enough room for the wisdom teeth, and so wisdom teeth have got to be extracted, and that's because our faces have developed smaller dramatically over time, even faster than really that is evolutionary possible. And of course, consequently, as the faces have not developed far enough forward, the jaws have developed back. And then, of course, we don't have enough room for wisdom teeth. So wisdom teeth removal is another topic, maybe another day, or maybe I can get into it at some point in time. But it has become obviously a very big industry in our country, and certainly there are times when it does need to be done because the face is just not developed forward enough to accommodate the wisdom teeth. In those cases, we simply really just don't have a choice. It's an unfortunate occurrence when we have to remove wisdom teeth, but it's certainly much more common than it would have been, 75 or years ago or so before the Industrial Revolution. It was rare to have that happen. So the reason why these arches have developed correctly, as I said before, is children immediately at birth are breastfed, okay, 100% of the time. Okay, they're breastfed mainly because it's the most economical thing to do. And when they are breastfed, they will do this for years, multiple years, and then they'll go directly from breastfeeding to solid food, meaning exactly what the parents are eating. Okay, there's no pureed food, there's no bottles, there's no sippy cups, there's no pacifiers. Okay, all these things teach the tongue to stay further down in the mouth. Okay, and since the tongue is a muscle and you can train a muscle to do anything you want, when the tongue is trained to stay down, okay, then the tongue will stay down. And if the tongue is further down in the mouth, the tongue is what again drives the maxilla here forward. And when the tongue does not go up there, there's nothing to drive this forward. Okay. And so that causes a deficiency in the maxilla and a deficiency in airway and facial development. Okay, so this is a little video that kind of illustrates that. I'll play that here.
A normal top jaw should look like this. The arch is wide and U-shaped, formed by the tongue as it rests in the roof of the mouth. There, it counteracts the pressure of the cheeks, which would otherwise push the upper arch of the jaw inward. However, if a child sucks their thumb or habitually breathes through their mouth, then the tongue drops from the roof of the mouth and the upper arch of the jaw gets pushed in to create a less attractive, longer, and narrower face with crooked teeth. In addition, when a child habitually breathes through his or her mouth, the top and lower jaws become underdeveloped and set back from their ideal position. This negatively affects the appearance of the face, making the nose look larger and, more importantly, reducing airway size.
Perfect. Okay, very good video. So when we look at these two pictures here, this is not genetics, okay? We have the picture on the left, which is really, unfortunately, what is the norm. But the reason why this happens is because the picture on the right, most oftentimes, this is the norm as well, too. This is what we can change, especially and have a profound impact on a child's growth and development if we do it while they're young, okay? So this is the effects of mouth breathing. We have a normal 10-year-old boy on the left-hand side, okay? 10-year-old boy, and then we can see what we got when he was 17 years old in the middle and on the right-hand side. Again, as you can see on the left-hand side, this has nothing to do with genetics. This had to do with the boy getting a hamster when he was 10 years old, okay? And he was allergic to the hamster, of course, unbeknownst by him or his parents. So he was allergic to the hamster. He could not breathe through his nose because his nose was clogged. And so he had to start breathing through his mouth. Nobody really paid attention. Nobody really understood what was going on. Okay. This could happen in today's society. And again, nobody would ever really notice because again, in school, dental school, medical school, these are just things that are still, we are just not trained on at all. So as he breathes through his mouth all this time, his mouth is open. As you can see, his jaws fall back. I show this picture so often in my clinic that I feel like I know this. Well, he's a man today, this young man, and I feel terrible for him, just because. And it still points out to me, life is not fair, unfortunately. But this occurrence that's happened, him getting a hamster when he was 10-year-old, has completely changed the trajectory of his life. He's going to certainly marry a different girl. He's certainly going to be less healthy throughout the course of his life. He's probably going to have a different job than he would have. And so all this has occurred because basically he got a gerbil or a hamster when he was 10 years old. But if this was caught early enough, this could have been completely reversed. One, it could have been avoided, okay, if they would have known. But two, it could have been completely reversed. And we'll talk about ways where you can actually reverse this. So again, we see this all the time. How this happens is that the tongue is not to the roof of the mouth. Okay, the tongue has got to be pressing up. What we've seen here is the maxilla, the upper jaw, has just continued to drop down. Okay, and that's why we see this really gummy smile. Whenever you see a gummy smile, it's because the tongue, the maxilla, has just dropped down. So the maxilla just gets longer and longer and longer. And we don't know exactly why yet, but this is more apparent in certainly some people more than others, where some people exhibit this look where maybe it's less widespread in some other individuals, but it's obviously a very unattractive look. She certainly is not happy about this. But again, could have been changed at a younger age, could have been completely avoided if the parents would have understood what was going on. Again, right here, we see this little crink in the nose here. Many women tend to be aware of this and don't like this. And the reason why this happens is because we've got a bone right here on our nose, the nasal bone here. And on the end of our nose is complete soft tissue. So as the maxilla is drifting down and back, it pulls the soft tissue of the nose just slightly back with it, and we get this little bump on the nose. This bump can get worse, certainly over time. There's cosmetic surgeries that you can do to fix that, the bump at least. but it's because the maxilla is continuing to drop down. You'll notice if you're old enough to ever be to a class reunion, a 20-year class reunion, some people look almost identically the same. Maybe they put on a few pounds here or there, but generally speaking, they look exactly the same as they did in high school. And then some people almost look unrecognizable. We think of after we get to, maybe 18 or 19 years old, that our growing and development is completely, set. But these occurrences can get worse, okay, over time into our 20s, into our 30s, and beyond, if again the tongue is not up to the roof of the mouth. At some point in time, things oftentimes reach an equilibrium and they'll stay and maintain. But for many people, that equilibrium is not reached. And so we'll continue to have facial changes and development changes in people, and their airway will consequently get worse due to that, even as they get older and older. So here we see on the right a really well-developed upper jaw, right? Very well. And on the left, we see a very narrow, we see a very deep palate, okay? Again, on the left-hand side, this is due to the tongue not being to the roof of the mouth. Okay, so again, tongue needs to be in the roof of the mouth. When the tongue is in the roof of the mouth, all the time as it should be, you will always have enough room for your permanent teeth, okay? So as I said earlier, the first sign of the tongue not being in the correct position to the roof of the mouth is not enough room for the teeth, okay? Or as we'll see later on here, when all the baby teeth or primary teeth are touching, we want to see spaces in the primary dentition, right? Because the permanent teeth are going to be larger. So again, this is what's called a CBCT, or a cone beam X-ray. We can measure the airway. Okay, on the left-hand side, we have an airway that's at 367 millimeters squared. Okay, ideally we want to be above 320. So the one on the left is fantastic. The one on the right, we're at 98. Okay, I saw a patient today; they were at a static position of 41. Okay, so obviously the person on the right is going to have a much more difficult time breathing. Okay, if you can imagine breathing, taking a straw from McDonald's or wherever you would get a straw from, and putting that in your mouth and breathing in and out of that, and trying to breathe in and out of that for very long, it is very, very labor intensive to do so. Okay, so what we can do, because everybody's adaptability is going to be slightly different. Some people, are at a 320 and they're in great shape. Some people could be at a 320 and have a very collapsible airway, okay, which is another problem. We can tell somebody's sleep patterns and how well they're adapting to whatever situation that they've grown accustomed to by taking a sleep test. That will definitively tell us if somebody has sleep disordered breathing. That is such a big deal, just because the chances of a heart attack and stroke go up by a factor of 4 if we have sleep disordered breathing. So we want to diagnose it. We want to diagnose this. We want to treat this, if possible, at very early stages for the health and well-being, obviously, of our patients. Okay, so this, again, most people would look at this girl and they would conclude that this is a very attractive person. Well, why don't we kind of sit back and kind of look at maybe why she's attractive? Okay, so we can see her teeth, right? Her teeth fill up her entire smile, right? There's no spaces on the side of her teeth and her cheeks. Okay, she's got a very wide smile. Generally speaking, this is very attractive looking. We don't have a lateral view of her. I've got another picture of somebody else, but we want this nice wide arch that fills up our smile. Okay, that's a great starting point. Okay. I call this picture the Beauty and the Beast here, okay? So if we're looking at the picture on the left, okay, obviously we somebody that most people would consider attractive. Okay, well, why is she attractive is always what I'm interested in. Well, if we look at her lower portion of her face, we see that it's developed slightly forward to her forehead, okay? Her nasolabial angle is almost at 90 degrees, okay? If she were to look straight ahead, her jawline would almost be completely parallel with the ground. Okay, where if we look at the gentleman on the right hand side, okay, well, if we look at his forehead, his upper and lower jaw are slightly behind. His face is elongated. You can tell that very easily compared to hers. And his jawline, right, is actually angled up. It's because it's developed forward and down as the faces got longer. Okay. So this is all just based off of certainly there's a portion of genetics that's involved, but for, as I said before, for us to reach our genetic potential, okay, our lips have got to be together, the tongue has got to be to the roof of the mouth, and we have to have nasal breathing. So this is where it starts here. This is the first thing that's got to be done. We've got to make sure that if we have a tongue or lip tie, that it is addressed. Now, mom can usually be the first person to pick up on this if there's not a lactation consultant. This is oftentimes misdiagnosed or certainly underdiagnosed in any hospital type setting. So lactation consultant is very good, or a dentist who understands the importance of this. Mothers who are breastfeeding a child like this oftentimes will be in really just sheer misery because it's very, very uncomfortable and very painful for them. So we want to fix this, and you can do this in a dental office with a laser very quickly. Have the mother breastfeed immediately after, and she immediately has relief. Now, sometimes when a mother has got a very high flow, now this is a pretty severe case that we're looking at here, but when a mother's got a very high volume of breast milk coming out, sometimes it can compensate for a child that is still tongue-tied. And so generally what will happen is the mother will breastfeed, everything is going good, and at some point in time when her milk flow gets less, then that's the time that the child will really struggle. Now, the immediate thought from the mother is, well, the child is kind of trying to quote unquote self-wean themselves. Well, that's really not the case at all. The child is just becoming increasingly frustrated because they can't get the milk out because they have to work so hard because they don't have complete mobility of their tongue. Okay, so we want obviously mobility of the tongue, complete mobility, okay, and we want mobility of the lip. This is what's called a tongue tie. So, I'm sorry, a lip tie. And so both of these things will take away from the child's ability to properly latch onto the breast. So this is kind of showing classifications basically of tongue ties. Obviously, we have a normal grade 1 over here in the upper left-hand side, and then we obviously have a pretty severe tongue tie in the lower right-hand side. But there's different classifications. Ideally, like I said, we should be able to open up our mouth completely as wide as we can, and with our mouth open, and we can measure that distance and touch our tongue to the roof of the mouth there, like is shown, and we should only decrease by about 20% or less as far as maximum opening. So this is what happens oftentimes in a patient who does not have correct oral posture or that is tongue-tied. When a tongue tie happens and it is not addressed, the tongue is going to, of course, rest in the bottom of the mouth. What this is going to do, it's going to push the lower jaw forward, okay? And so we're going to have a deficient maxilla because, again, the tongue is in the bottom of the mouth. The tongue obviously is designed to bring the upper arch forward, but it will do the same thing on the lower arch if this is where it's always resting. Okay, so this is a picture of a child in primary dentition. Okay, we can see here that they've got plenty of spaces in between the teeth. Okay, now obviously they have a little appliance in here that I put in to gain these spaces here. So this is very good. This is what we want to see in a primary dentition, but we can also start to see growth developing in the wrong direction. We can already see here that she's got somewhat of a little gummy smile. Okay, not severe, but as we're going to see here moving forward, that this is going to get worse. Okay, now obviously we're developing the arches here, so she's got enough room for the permanent dentition, which is certainly valuable. But if we can, we want to fix or correct the growth problem that we see here as well too, and we will do that. Okay, so just to reiterate, right, we need 3 things for correct oral posture and facial and dental development: tongue to the roof of the mouth, lip competency, meaning lips together all the time, right? I tell the little kids in my office, you can talk, okay, that's permitted, okay? You can laugh, okay? You can smile, you can eat food. Other than those periods of times, we want your lips to be together at all times and your teeth lightly touching. That's not as important, but lips together. We don't want them just slightly apart. We want them all the way together, nasal breathing and tongue to the roof of the mouth. So this is kind of just a picture of just showing what's correct oral posture looks like inside the mouth, right? The tongue over on the left-hand side is all the way to the roof of the mouth behind those front teeth, right? As you can see, if you swallow about 2,000 times a day, when you swallow, that tongue is pushed forward, okay, and laterally. So that's what helps develop those arches, and that's what drives the maxilla forward. Okay, so as you do that, that tongue has almost got like a wave motion, and so the back of it goes up, okay, and then you come back down to your ability to breathe. And so what this does is, again, it develops this upper portion of the jaw. Because the lips are together and the teeth are in light contact, it's going to help the lower jaw develop as well. Okay, so to facilitate good oral postures, we kind of talked about before, breastfeeding as long as possible. A year and beyond is even better. If we can go even longer than that, that's okay. If we need the help of a lactation consultant, that's always a very good thing too, or a properly trained dentist to be able to analyze this. And then we're going to go from direct breastfeeding to solid foods. This is the book Baby-Led Weaning. Many things make our lives easier. I mean, we live in a society that generally loves to do things to make our lives easier, and I understand the appeal of that, but very few of these things that make our life easier actually improve our lives in the end. So there's a lot of things here. Again, bottles, sippy cups, squeeze and goes, processed foods. The list goes on. All these things have a negative impact on growth and development. So this is a picture on the left-hand side of what it looks like when a baby is breastfeeding. When a baby is breastfeeding, that tongue is getting pushed up to the roof of the mouth to extract the milk out, okay? And that's what helps developing that upper jaw there. When a baby is tongue-tied and they cannot push the roof of the tongue to the roof of the mouth, then it's going to become oftentimes very painful for mother, and the child will become extremely frustrated at their lack of ability to do that. So if we are not able to get proper facial development, okay, these are all the things that can happen. Upper airway resistance syndrome, which is just a form of essentially sleep apnea, obstructive sleep apnea, okay, attention deficit disorders in kids. We see kids that have ADD or been diagnosed with ADD, I should say it that way. The ADD symptoms and sleep deprivation symptoms are exactly the same. Any child that gets diagnosed with ADD should be diagnosed by somebody that's properly trained for for a growth and development consult. I can't tell you how many children that I have treated over the course of my career that have had this exact diagnosis, that the whole time it was just a sleep problem. There's a very good video out online on YouTube. It's called Finding Connor Deegan. It's on YouTube. It's a mother's story of basically her son completely going in the wrong direction as an adolescent, and luckily her persistence allowed them to find the answer, which was really just making sure that he slept, okay, during the night. So snoring, allergies, the list goes on as far as the consequences of the face not developing properly. Okay. What options do we have for correction? Okay, well, there's traditional orthodontics. We'll talk about traditional orthodontics. Traditional orthodontics is really not a very good option here, at least in my opinion, most of the time. Okay, traditional orthodontics is designed to straighten the teeth. Okay, and by straightening the teeth, most oftentimes negative things happen. Now, if the whole goal is to just make the teeth straight, well, traditional orthodontics does a fantastic job. Their goal is to make the teeth straight. They want to get people in what's called the class 1 occlusion, okay, which again, there's no literature showing that a class 1 occlusion equates to any type of health benefit at all, but it's what's been taught over the years. And certainly it's a more appealing, it looks nice and it looks good, but again, there's no studies to show class 1 occlusion equates to health, okay? Myofunctional therapy, which we'll talk about, breathing re-education, non-retractive orthodontics, okay, so there's a key word, or what could be considered airway orthodontics. Airway orthodontics, unfortunately, is becoming just a buzzword. Everybody's doing airway orthodontics, but they're doing traditional orthodontics, and they're calling it airway orthodontics. So that's really doesn't mean as much as it should or it used to be over the years. Orthotropics, okay, we'll talk about that. And then, of course, surgical options, okay? So this is traditional orthodontics, okay? These are brackets and wires that are put on the teeth over here on the left, on the lower right. You could see this. This is done, you know, thousands of times, tens of thousands, hundreds of thousands of times each day across America. So when you put brackets on the teeth, of course, on the outside of your teeth, and this is always the last stage of orthodontics over here on the right-hand side, is they'll put what's called an elastic chain that goes around all the teeth. Okay, so you're connecting teeth in the back of the mouth, okay, that have 3 roots on them. Okay, you're connecting them to teeth in the front that have 1 root. Okay, so it does not take a rocket scientist to figure out if you're trying to move a 3-rooted tooth or a single-rooted tooth, okay, which tooth is going to be moved easier, right? Everybody's going to say the single-rooted tooth. So when you attach a wire to all these teeth and you put an elastic around all these teeth, which again, this is always the last step to any orthodontic treatment, because an orthodontist, the last thing they want is having any spaces in between the teeth. So what this does is it pulls the teeth back. Okay, it pulls the teeth back. And this can be measured objectively by almost anybody. If you measure, and we'll show you how to do this here in a little bit, you measure what's called the cosmetic line, which is the distance from the tip of the nose to the incisal edge of any one of these front 2 teeth. Okay, you're going to get a measurement. If you start that measurement at the beginning of your orthodontic treatment, traditional orthodontic treatment, and you measure this at the end of your traditional orthodontic treatment, you will see that this number gets longer because things have been pulled back. Okay, so that is called retractive orthodontics, which is really what orthodontics should be called because that's exactly what it is. Again, you're putting a wire on the outside of the teeth, okay? Well, by putting a wire on the outside of the teeth, the most likely position that those teeth are going to move is backward, okay? And then, of course, you're putting a big elastic wire around these, okay? So, again, you're pulling teeth back, okay? Then you have on the left-hand side, you have an elastic, then this is done all the time as well too, where it's actually an elastic that's going across the arches, okay? Now we say, well, we may get some movement of that lower jaw forward, which may be true. We may get a little movement of that lower jaw forward, but we're also going to get movement of the upper jaw backwards, okay? And again, this is the last thing that we want to do in the upper jaw, because we want the tongue to be in the roof of the mouth all the time. If the tongue is to the roof of the mouth all the time and we've pulled the upper jaw back, okay, we've all of a sudden pushed the tongue into the back of the throat, okay, which is the last thing that we want to do. These two things, these 2 pictures right here are what happen in orthodontics every single day. And if you had orthodontics, most likely happened to you as well too. Now, this instrument on the left is what's called a Herbst appliance. This is also a mainstay in traditional orthodontics. A Herbst appliance is designed to, so let's say your top teeth are here and your bottom teeth are back here. And this is called a class 2 bite, okay, where the upper jaw is really far out in front of the lower jaw. So what the slide that we saw earlier, we could maybe put some elastics there if it was small enough. But what's going to happen a lot of the time is they're going to use what's called the Herbst appliance. The idea of the Herbst appliance is to push the lower jaw forward, okay, so we can bring that lower jaw forward. And that idea, that's a good idea, right? But because this appliance cannot defy the laws of physics, instead of pushing the lower jaw forward, you may be able to get a little movement of the lower jaw forward. That's possible, but you're also going to get the upper jaw coming backwards, okay? And again, this is a cardinal rule, a cardinal sin in any type of health airway treatment is we do not want to pull the upper jaw back. If you take the cosmetic line, and again, I'll show you how to do this in a little while, the upper jaw is already too far back. If you live in the United States or westernized culture, your upper jaw is already too far back before you start orthodontics. So the last thing that we want to do is pull the upper jaw back any longer, okay? You're making somebody's health worse if you do that even 1 millimeter. It has been shown in many cases by pulling the teeth back 1 millimeter, you can induce snoring in an individual. Now, will you? Well, you don't know that, of course, but health is not something that ideally we should be gambling on, at least in my opinion. So we do not want to pull these teeth back at all. Okay, so here is a another very good treatment that I think most all children should do. All my children went through this, some more successful than other based off of the child, but it was worth it to me for all the children to go through. So myofunctional therapy is essentially physical therapy for the tongue, okay? The tongue, for many reasons, as we talked about, you may had a tongue tie, you may just not, you may kind of quote unquote had a lazy tongue, just not very well trained for whatever the reason is. Myofunctional therapy teaches the tongue to stay into the roof of the mouth where we want it to be. Now, this is done through specific training and through specific exercises with the myofunctional therapist. We have two myofunctional therapists in our office that are very good, but there are myofunctional therapists across the United States, very talented ones. And most of these things can be done via Zoom calls. So I encourage almost all children to do myofunctional therapy. Certainly by looking at somebody, we can tell oftentimes, again, what their lip competency is, right? We see children all the time. If their lips are ever chapped, this is a very good clue. If your lips are chapped, it's not because you're dehydrated, okay? It's because you're breathing through your mouth. So if your lips are chapped, you or your child's, it's because you're breathing through your mouth. Now, you may not realize it. You certainly may not realize it that your children are doing it, but that's what's occurring. You know you're breathing through your mouth if your lips are continually chapped. We can certainly look at somebody or ourselves and go like, yes, lips are together. Of course, if the lips are together, we're going to be breathing through our nose, so that's good. But oftentimes we cannot tell where the tongue is or where it's resting at. So myofunctional therapy, if it's done correctly, okay, and successfully, we know that the tongue is to the roof of the mouth where we want it to be. So this is just so important. There's been a number of clinical studies done on myofunctional therapy showing its reduction in sleep apnea for adults and children. So it's very powerful, very worthwhile doing, and we are certainly big proponents of and thankful for all the myofunctional therapists out there. So there you go. The myofunctional therapy alone decreases sleep apnea in children by 60% and in adults by, 50%. So there's lots of literature out here and it is very beneficial. Again, as I said before, we encourage people to do this all the time, children and adults. Yes, it does. We call it myofunctional therapy, essentially physical therapy for the tongue. It does take some work to do. It does take some persistence, but at least in my opinion, most things in life that are worthwhile doing take some work, take some persistence to complete. It's not difficult at all, but we have to kind of, be disciplined enough to be continually doing it every single day. It's like an exercise, right? Whether you're trying to get your biceps stronger or your legs stronger, trying to increase your cardio, right? You're going to have to get on the treadmill or lift the weights every single day. Myofunctional therapy is no different than that. So these are just a couple, not great pictures, but a couple things, a couple pictures that illustrate kind of with myofunctional therapy, pre-myofunctional therapy on the left, okay, and after myofunctional therapy on the right. They did nothing else except myofunctional therapy. We always have to remember that the position of the teeth is going to be based off of the pressure of the tongue, okay, against the pressure of the lips. That's going to dictate where the teeth are at in the end. So, after every orthodontic treatment, what's the orthodontist going to do for you? You're going to get a retainer, right? Even in my office, most of the time you will get some type of retainer, right? Because I don't, and the orthodontist doesn't know exactly where that tongue is. In a perfect world, your tongue would be the retainer. Your tongue is God's retainer. If your tongue was in the perfect position, one, you would never need any type of orthodontics, but two, you would never need a retainer. Okay. If your lips are together, you had nasal breathing and tongue to the roof of the mouth, you would never need a retainer. So this has become very popular, right? Lip taping. So in that book, it's called Close Your Mouth. It talks about lip taping. When we breathe through our mouth, it doesn't matter what we're doing, whether we're running a race, watching TV, or certainly sleeping, we exhale too much carbon dioxide. Okay. Carbon dioxide is a smooth muscle relaxant. Okay. So when we exhale out, for whatever reason, we off gas CO2. So consequently, our lungs are going to get smaller. Okay. And our blood vessels are going to constrict. Okay. This is something that is not advantageous to health. We want to maintain the appropriate amount of CO2 in the body. The only way to do that is to breathe through our nose. So lip taping is kind of like a Band-Aid, no pun intended there, but kind of like a Band-Aid to accomplish that. But again, obviously, oftentimes when we're sleeping, unless we went through myofunctional therapy and went through that training to ensure that we have lip competency, lip taping is very effective at making sure that, again, we're breathing through our nose. This is something that I do religiously every single night when I go to bed. I'll have pillow chat with my wife, and then, I'll put on my piece of tape over my lips, and she will do the same thing. I'm addicted to doing this because I know that I sleep better. I feel better when I wake up in the morning when this is done. Back in the day before they had inhalers and an asthmatic was having an asthma attack, okay, what did they have the asthmatic do? They had them breathe into a brown paper bag, right? And the reason why they had them breathe into a brown paper bag is because an asthmatic is always on the verge of having an asthma attack, and it's because their lungs are continuing to contract and they just can't get enough air volume. When they breathe into the brown paper bag, they're breathing back in their own CO2, which is giving them an appropriate amount, and their lungs are expanding. And as the lungs expand, the volume of oxygen that can be absorbed goes up exponentially. So again, we always want to encourage, again, this is one way to encourage breathing through the nose.
Habitually breathing too much air into the lungs contributes to the cooling and drying of the airway walls. Depending on genetic predisposition, this can cause the airways to inflame and narrow, resulting in wheezing, coughing, and breathlessness. When breathing volume is changed towards normal by breathing through the nose and practicing to breathe light, the airways re-expand, resulting in significant reduction of asthma symptoms, improved asthma control, and a reduced need for medication.
There we go. Okay. So another solution for airway problems is what's called orthotropics. Orthotropics is called face growth guidance. This is a little girl over here on the left-hand side. Again, you can see that she's not developing great, okay? We've got a really severe class 2 overbite over here on the lower left-hand side, and you can see what she turned into on the lower right-hand side through orthotropics, okay? Oh, there's a little video about that. Again, we see what on the left-hand side, normal face, okay? And then we see a nice attractive face on the right-hand side. This was done through orthotropics. The only way to do this, orthotropics is essentially surgery without a scalpel, but you've got to get the kids at the right age to be able to do this. You have a small window to be able to complete orthotropics. Okay, so this is my daughter. I already showed her a picture earlier. You can see that she's got a much gummier smile than she did before. Okay, again, great. We have enough room for all of the teeth. You can see we have spaces in between all the teeth, which is great, but she's growing, her face is growing downward. Okay, through orthotropics, we were able to change the trajectory of her face and growth. This is her several years later. We can see a nice growth. The teeth, the gingival margins is right at her smile line, and we've got good growth forward development. Okay, we can see the difference there. On the left-hand side is a very young girl. We can see how things are going down and back. On the right, we can see how well things have developed forward. Okay, this can only be done through orthotropics. Okay, so here's just a little quick video that kind of goes over orthotropics.
Here's a question for you. What would happen if your child's jaws were growing down and back in the face instead of forward? Unfortunately, faces like this have become the norm in modern society. The upper and lower jaws have grown down and back in the face. Aside from the less appealing appearance of a face that grows this way, down and back facial development can also lead to a smaller airway, sleep disordered breathing, snoring, behavioral problems, jaw joints that hurt and don't function properly, a long face with a weak profile, and least important, but usually easiest to spot, crooked, crowded, or buck teeth. Believe it or not, these symptoms tend to get worse as children grow if the problem is ignored. When a child's face develops properly, he or she will most likely have healthier jaw joints, a better looking face, straighter teeth, and by far most important, a larger airway. A larger airway means better breathing, better sleeping, and better health. So what's a parent to do? Learn more about orthotropics. Orthotropics move the upper front teeth into their ideal position in the face, then develop the lower jaw forward, which in turn leads to proper facial development. The benefits of orthotropics are powerful. Kids who succeed at orthotropic treatment tend to have wider airways, healthier jaw joints, stronger profiles, and terrific smiles. The orthotropic process is simple. Removable appliances are used to first develop the upper jaw forward, then the lower jaw forward. But here's the disclaimer. Simple doesn't mean easy. Kids and parents who want the benefits of orthotropic treatment have to be willing to stay the course. The appliances must be worn, and the kids have to stick to the program or the treatment won't work. Let's go back to our original question. What would happen if your child's jaws were growing down and back in the face instead of forward? Your child could be headed towards some or all of these problems. Orthotropics works for kids as young as 4 and if your child is under age 10.
Okay, so that is orthotropics, okay? Orthotropics, as you can see here, we have an airway on the left and an airway on the right, okay? An airway on the right is really what we're going to want to have, okay? So it is, unfortunately, there are not very many practitioners that know or have been trained in this. This is a very specific type of treatment that is done that very few people know how to do. Certainly, as far as orthodontics go, there's very few people that have been trained to do this. So that's the unfortunate thing about it. Also the unfortunate thing about it is every child is not a good candidate for, unfortunately. You have to really have a stable home, a disciplined home, because as the video alluded to, it is not the easiest treatment to do, okay? There were times when I was doing it for my own daughter that I was wondering if it was going to work. For me, it's a kind of a challenge there. I'm the doctor at the office, okay, but I'm dad at home, okay? So when I had to be the doctor at the office and at home, okay, it creates a strain, obviously, in the relationship. Now, for whatever strain it did cause, I am really glad now that I have the results that we got from her treatment, but it is not the easiest treatment in the world, and so unfortunately, every child is not a candidate for this. But my goal here is just to put this information out there so parents are aware, okay? There are some other options as well too, okay? So the other options that are, again, non-retractive in nature, meaning things that do not pull the teeth back or cannot pull the teeth back, which is what we're trying to do, is ALF orthodontics or Crozat orthodontics, which is kind of the same thing. We'll talk about that. You can reopen extraction sites orthodontically. I know a lot of adults have had premolars removed. Okay, when premolars are removed, the upper jaws and the lower jaws get pulled back. And surgery is another option as far as that goes as well too. So this right here is a Crozat. Basically, it's just a wire, okay, that snaps into the roof of the mouth and in the bottom, and it sets on the tongue side of the teeth. So what we're able to do with this appliance is we're able to really three-dimensionally push things out laterally and forward, okay? It is not orthotropics, but it's probably the second best thing that can be done for a child. Again, we're trying to do everything that we can to create more room, but we are not going to compromise pulling things back at all. Okay, it's just something that we refuse to do. Okay, this is ALF. Okay, this is just essentially the same thing, but a different type of wire, kind of in a little bit different shape. In the end, I don't think that these differences really matter the most. What really matters is that, again, they are not retractive in any way. And this is surgery. This is what can be done. Let's say you get to be 17 years old and you know that your face and airway have not developed the right way. You can have surgery done to correct it. Yes, these are the same exact people. And so there's a few surgeons out in the country that are very, very good at this. Dr. Wolford in Texas and Dr. Reza in Missouri are two phenomenal doctors, the only doctors that I would really send anybody to for this type of treatment. But again, it can be really life-changing. As you can see there, the late girl on the right-hand side is just more attractive. What doors is this going to open for this girl? I mean, who knows? But certainly she's very happy with the results. Surgery is not always there are downsides to surgery, as most people know. And so again, you just need to be well informed about what the risks are, and then and what the pros are in your effort in deciding something like this. But she did decide it, and she's very happy. Okay, so as I was telling earlier, okay, the cosmetic line. This is a little instrument that we have in our office where we can measure the cosmetic line, right? The distance from the tip of the nose to the incisal edge. We do this on all the kiddos or anybody that we're doing ortho treatment on. We want to make sure that, again, things are going forward and not getting pulled back, okay? So we can look at this ideal measurement line, and we can see over here on the left-hand side, for a male, let's go with a 10-year-old male just to make the math easy. We would take male 23 right here plus the age in years. So we would add 10 years. So that ideal measurement for a 10-year-old boy should be 33 millimeters, okay? If it's beyond 38 millimeters, okay, then that's when we're going to at least consider, at least in my mind, of like maybe orthotropics might be a treatment for this child if they have a stable enough environment to be able to accomplish that. For a girl, it's a little bit different. It's 21 plus the age. Okay, so 21 plus 10 is going to be for a 10-year-old girl. That ideal measurement is going to be about 31 millimeters. Okay, so this is something and we're able to track, and it's very easy, very reliable predictor over ideal facial growth and development. You can tell where a child is in their growth and development, and you can tell the direction that they're going to as well. So the cosmetic line or the mu indicator line, those are both the same things, right? That's what they're doing. They're measuring that distance. This is just a side view from the tip of the nose to the incisal edge, right? In a case like this, you're going to say, or most people would say of like, oh, geez, the upper jaw is too far out. Well, that is really not the case. The upper jaw is not too far out. The upper jaw is still too far back here. The front teeth need to be brought forward like the video showed, and then the lower jaw brought forward without sacrificing the upper jaw. That's the beauty of orthotropics, is we get complete forward development. The upper teeth get moved out into the ideal position, and then the lower teeth get brought into position so that there's no retractive effect on that, okay? Very, very neat treatment, okay? So we are kind of shifting gears here a little bit. We went through growth and development, okay? If anybody has any questions, please, you feel free to ask any questions. I will do my best to make sure that we have a chance to answer all of them. This next segment isn't going to last a long time, but I want to make sure that I have a chance to answer any questions that are out there. So we're going to go into kind of biologic dentistry. So this is a little video that kind of illustrates in a very, I think, a very effective, simple way of biologic dentistry. Okay.
Teeth are like the circuit breakers of the body. If you've ever had a circuit breaker flip in your house, you know that no matter what you do to turn the lights on and off, it's not going to work because the breaker is flipped. When an embryo is forming, the brain forms first. And then the circuits develop from the brain down into the embryo. And they go through very specific teeth before continuing on into the different areas and organs of the body. Therefore, the teeth become an integrated part of every acupuncture meridian or circuit.
If a tooth decays, the decay acts as a resistor and reduces the voltage in that circuit. There's an infection in the tooth or the bone around the tooth. It acts as a circuit breaker and switches the flow of voltage off completely, which prevents voltage from reaching the body members on that circuit. To learn more about how dental infections cause low voltage, go to synergy.us.
So there you go. Very, very good video there.
Yes.
Okay. Well, let's skip there. Okay. So there are three types of infections that we focus in on. The first is the periodontal infection. Periodontal infection is infection around your teeth and gums. Lots of research that's been done on this for well over 25 years, showing its direct correlation to cardiovascular disease, heart disease, diabetes, and Alzheimer's. Okay. The only way that we can definitively tell if we have a periodontal infection is by taking a sample of the plaque that's around the teeth. Okay, we have to take a sample of the plaque around the teeth to be able to identify that there is an infection. We look at that underneath the microscope and we can definitively tell. That is the only way that we know for sure. Then what we will do is we will take a sample of that plaque and send it off to a lab for a DNA analysis. By doing this, we can kind of tell if what the threshold levels are of those bacteria and get an exact idea of these bacteria, so we can fight these bacteria specific to what they are. But that is periodontal infections. Okay. The next type of infection are periapical infections, and those are infections that are typically around the roots of teeth. Okay. Typically, we will see these around root canal treated teeth. Okay. This is kind of a controversial subject in dentistry, but all root canal treated teeth are infected. Okay. Dentistry is the only healthcare profession in the entire world who thinks that it's okay to have a dead piece of tissue inside the body. Okay. So we are not a proponent of that. The American Dental Association, I think I have a slide here on that. The American Journal of Endodontics is all in their own literature stated that, again, systemic disease is correlated to root canals. And again, that's because they're dead tissue. So we see here on these x-rays, these dark shadows around the teeth. Okay. These are infections around the roots of the teeth. On a two-dimensional x-ray, these are missed about 80% of the time. Okay. On a three-dimensional x-ray, there's a much higher likelihood that these type of infections are caught. And again, periapical infections, periodontal infections, and then the third one, cavitations, are all silent infections. They rarely ever cause any pain. Okay, so that's the danger in them. They do not cause pain. Okay, so this is a very great book. It's written by a good friend of mine, Dr. Thomas Levy. He's a board certified cardiologist. He wrote a book on there called The Hidden Epidemic. The whole book is about root canals and the dangers of root canals. The take home message in this book is he tested 5,000 root canal treated teeth, sent them off to a lab for a DNA analysis. 5,000 out of 5,000 of them came back infected. Okay, 97% of women who have breast cancer have a root canal on the same side. And in Dr. Levy's opinion, the first step to having a heart attack is to have a root canal treated tooth. Okay, so again, we do not advocate people get root canals, but we understand we also believe in medical freedom. People have the choice to do what they want to do, so it's our job to give them all the education and then let them make their choice on what they want to do. If they want to get a root canal, I'm okay with that. But I am not okay with them getting something when they do not know the risks associated with it. And there are many. Here you go. Here's this from the American Journal of Orthodontics, or American Association of Endodontists, excuse me. In 2017, the conclusion was systemic disease related to root canals in their own journal. Okay, so this is not new information here. Okay, the third type of infection is what's called a cavitation. A cavitation is an infection in the bone. Okay, cavitations generally are going to happen due to lack of blood flow. Okay, that's really going to be the cause. Lack of blood flow can be caused by systemic conditions like hypothyroidism, lupus, radiation treatment, nitric oxide deficiency, or diabetes. Okay, but it also can come from dental trauma. When a tooth is removed, okay, and if a blood supply is not reestablished back to the area, without blood and oxygen, tissue dies, bone dies. And we can see a cavitation here on the lower left-hand side. This creates inflammatory markers in the body and is just simply not healthy. It's dead tissue inside the body. Okay. The third thing that we're going to talk about, we talked about infections. Okay. We talked about airway health, obviously. The third thing is metals. Okay. Metals corrode. Okay. That's our starting point there. The Food and Drug Administration, which normally I do not take health advice from the Food and Drug Administration, they issued a report on metal implants, okay? Metal implants corrode inside the body as well too, just like any metal does, and certainly in the mouth it's going to corrode faster, especially if you have dissimilar metals inside the mouth. Okay, so this is right out there from the Food and Drug Administration. There are many other articles as well too. We are generally not in favor of really any metal if we can that is permanently fixed inside the mouth, because again, you are going to have some corrosion inside the body. We know corrosion leads to inflammation in the body. We know inflammation leads to disease. Okay, so again, these are mercury fillings. Okay, mercury fillings are 52% mercury and 48% metal. We do not like the metal component of this. We also do not like the mercury component of it as well. Mercury is the most toxic non-radioactive substance on the planet. Okay, I'm not overstating that at all. Again, I will say mercury is the most toxic non-radioactive substance on the entire planet. Now, if we're going to get these removed, we want to just make sure that we do so in a safe manner. There is a protocol called the SMART protocol, Safe Mercury Amalgam Removal Technique, that minimizes the danger, okay, of getting these removed. But every time you chew on these, every time you do anything on these, touch your teeth together, there is mercury vapor that comes off of these, unfortunately. And then we have it over on here on the right-hand side, just a traditional porcelain fused to metal crown. Okay, again, these are made out of metal, so metals corrode. Okay, corrosion leads to inflammation, and inflammation eventually leads to disease. Again, if your dental crown, there's nothing wrong with them, I'm not going to be the advocate that says that you need to replace these, but it is also my responsibility to tell you what is going on in regards to your health and let you make the appropriate healthcare decisions. Okay, when we're talking about digestion, okay, and all these infections, whether it's an airway problem, whether it's an infection, periodontal, periapical, or cavitation, or whether we have toxic materials in the body, all the real reason of why all these things are terrible for us is because of what they do to our digestive health. All these things are hooked into the what's called the autonomic nervous system. The autonomic nervous system is composed of the sympathetic and parasympathetic, sympathetic being fight or flight, parasympathetic being rest, digest, and heal. Essentially, your sympathetic nervous system is activated when we have infections in the body because the sympathetic nervous system is activated because inherently it knows that if an infection gets out of control in the body, it has the potential to kill you if it gets out of control. So it's going to divert resources away from digestion to make sure that the infection is taken care of, okay? And that system works really good, okay? But the problem is if digestion is ignored for, or compromised for 5 or 10 or 20 years, okay, the results are that we're not going to be able to make enough new cells to replace old cells. If we cannot do that, okay, then that's when that's going to be the starter to chronic disease. So our goals are pretty simple and focused. We want to make sure that we can breathe well. We want to make sure infections are eliminated, okay? We want to make sure toxic materials are removed in conjunction to our health. Okay, so that is the end of my presentation today. I certainly appreciate everybody coming out. Certainly, if anybody has any questions or anything, I'd be happy to sit here and answer them. I can see them up on the screen here. I'll sit here for a couple minutes here and be happy to answer any questions. If not, I appreciate everybody that hopped on tonight. If you have any questions, you can contact either one of our Gillette office or Sturgis office, or through our website or through email. But thank you very much for everybody coming out tonight. Thank you, and have a happy Thanksgiving. I'll sit on here for a couple more minutes. Okay, so we have a question. Stephanie, okay. What causes appropriate spacing of teeth in toddlers? Well, what causes the appropriate amount of space is the tongue. Okay, again, the tongue is what drives the upper and the lower jaw. So if the tongue is to the roof of the mouth where it should be, it's going to cause the teeth to spread out. The primary teeth, the baby teeth, are small. So the jaws don't have to be very well developed to create space. So the answer to that is the tongue. The tongue is what creates the appropriate amount of space. If the baby teeth are touching, okay, or certainly overlapped, okay, or we don't have enough room for the baby teeth, we know from a growth and development standpoint, we are not going in the right direction. We are going in the wrong direction. And so certainly when we start going in the wrong direction, okay, we're talking about a major health event here, because if we are not breathing correctly or appropriately, okay, that's going to affect every other biologic function in the body. Okay. So I mean, I can think of few things that are more important. Okay. There isn't anything more important than your ability to breathe. Okay. We can go without water for a long time. Okay. We can go without shelter for a long time. We can go without food for a long time, but we cannot go without air for a very long time. And Dawn, you're welcome for this information. I hope, like I said, it was helpful. It's something, like I said, that I'm passionate about, just because I look around and I see these problems. And this should be parenting 101, at least in my opinion. But I was never given this information when I was having children, when my children were small. I never learned this information when I was in dental school either. So it's just it's a sad thing that more parents aren't aware of this. And so it's my job and my duty to be able to share this information. So thank you. We have a question: what does the typical myofascial therapy program look like? Generally, you're looking at, and thank you for the question. Generally, you're looking at about a year. Now, different programs will obviously vary, but generally you're going to either go at the beginning once a week. So generally it's once a week. You'll do that. Have the visit with the myofunctional therapist. They'll go over specific training and make sure you're doing the tongue exercises correctly. And then it's going to be your responsibility to do the following week. Every single day, probably a couple times a day. Now, again, in the course of a whole day, it probably takes 15 or 20 minutes, maybe. Some programs are you're going to see them every other week. So the programs are going to vary depending on what the myofunctional therapy, through her experience, finds out works the best. But generally speaking, you're looking at, from beginning to end of treatment, you're looking at, an extended period of time. Remember, for muscles to be trained appropriately, you're right, they've got to be stimulated and worked consistently over a period of time. So I would say a longer period of time is probably going to be generally be better than a really short period of time. I'd love if we could get it done in 2 weeks, okay? But I would be very skeptical over a program that was really, really short. Thank you for the question, Gina. Okay, so I'm just waiting here to see if we have any other questions at all. Okay, so what if a child is older than 10 years old? Okay, well, that's going to depend on the orthotropics video that we saw earlier. It kind of gave an age range there. It really has to do with their dental age and not necessarily their biologic age. Okay. So their dental age, they've got to really have some primary dentition left to be able to accomplish this the way that we would want to. Now, there are ways to kind of get around that or fudge around that, but it's going to be very patient specific. So we're looking at their dental age. We want them, probably around 10 or 11 years old. But again, people's dental age always does not correspond with their biologic age. But obviously, if we're talking to the general public, we're going to say around the age of 10, because they may not be aware of what their child's dental age is compared to their biologic age. So that's just a guideline. Generally, girls are going to develop a little faster than boys, but again, that's certainly not an absolute. But great question there, Jared. Okay, the next question here is, do any of the water bottles with straws promising better oral development and sleep actually work? That's a great question. Thank you for that. I would probably, drinking out of a cup is going to be a better way to drink than out of the straws, right? Again, most of these devices, any device that encourages the tongue to stay in the floor of the mouth, there's probably 1,000 of these out there. Some of them may work better than others, but we're wanting to mimic proper swallowing patterns. So that slide I showed earlier, The tongue has got to be pushed to the roof of the mouth, and then the water goes, or the fluid or the food goes over to the back of it. So something that encourages the top of or the tongue to go to the roof of the mouth would be a good device. I don't know that I'm pretty confident that that is not going to replace myofunctional therapy, but can it be supportive? It could potentially be, depending on the device. There's lots of devices out there. Some certainly probably be better than others. I would personally be really skeptical of it, and that's not to say that there aren't some good devices out there, but I would be skeptical of those. Okay, so I had a question here. In adults with metal implants, can they change to ceramic implants? Yeah, so I apologize for that. I talked about the effects of titanium implants, but I did not give anybody a solution to that. So the solution to that is a ceramic implant, and that's the only type of implant that I place in my office is a ceramic implant. So yes, if you do have a metal implant, okay. Unfortunately, it is corroding inside the body, unfortunately. But yes, that can be replaced with a ceramic implant. So that's something that we commonly do in the office for people who want that type of treatment. If certainly if a person knows the risks of a titanium implant, then certainly it's not my job or my responsibility to talk them into removing that metal implant. That's not my goal at all. I want to just be a vessel of information to my patients so they know the risk. It'd be the same thing, and I give this example often. If one of my patients decided to start smoking, I would certainly encourage them not to do that, to smoke, but because they know the risks associated with it and they still live in the United States of America, it is their right to do so. So that's what I'm trying to do is bring awareness to patients about the risks. There's very few things that have zero risks in them. And certainly things that have been introduced into medicine and dentistry that have been in the field a long period of time, in my opinion, do more harm than good most times. And so it's my responsibility just to inform the patient and then meet them wherever they're at, regardless of what it is, and hope for, and the goal should be better health. Um, Okay, the next question. Great. I love these. And I'll stay here as long as the questions come, as long as there's not too big of a delay in the questions as far as time goes. Okay, should children mouth tape? And if so, how can you start? And at what age can you start? Fantastic question. So, yes, children should mouth tape, especially if they're mouth breathers. Okay, so certainly the gold standard is going to be, again, myofunctional therapy, but maybe your child is 3 years old and you know that they're not going to go through myofunctional therapy. So, what can you do to encourage mouth taping earlier? So, one thing that works for most parents is if you allow your child to have any screen time, and you could, if you don't, I mean, kudos to you for that. But if you allow your child to have any screen time, what you can do is you have to be the enforcer in the home for at least a period of time. You can make a trade with them. I will give you screen time, okay, as long as you have your lips taped. Now, if you put a piece of tape over your lips right here in the middle, okay, I can still talk and I certainly can still breathe. So your child is not going to suffocate from putting a piece of tape over their lips like this. You make a deal with them. I will give you screen time and I will give you extra screen time, but you have to have your lips taped. Okay. And it's a rule. You can't go back on that. They will quickly learn that lip taping, keeping their lips together, that they almost prefer it. Okay. My daughter going through orthotropics, okay, we were struggling, right? I was the doctor at the office and the doctor at home, and it was becoming a drain on me and it was a drain on her. She quote unquote lost her appliance that we never could find for a period of time, right? So I had to ship it off to California to have a new appliance made and had it sent back to us. We got the new appliance and I put it in her. And from that day forward, it was just like she sailed right through it. We got done within just a month or two. And the reason why that is because she could tell the difference of her jaw in the proper position. She felt better. She slept better. So again, this application applies to lip taping. People that lip tape consistently continue to do so, and I'm one of them, because I know I feel better in the morning when I do it. So a child is going to recognize that subconsciously after they get past the weirdness of it, maybe, that, wow, I really do prefer breathing through my nose. They may not realize it, but they will. So you'll make that trade with them on screen time to be able to do that. And then what you can do is when that becomes no big of a deal, when not a big deal at all, you can transition that to nighttime wear. Okay. Of course, putting a piece of tape over their lips at night, just like this, right? That's the uncontrolled. You can be on their case during the day, all day long, close your lips, close your lips, and close your lips. Okay. But certainly at night where, you're asleep, they're asleep, you don't really have any control over it. So again, we really just have to focus all our attention on keeping those lips together and again, these are muscles. Okay. So it is just muscle memory. This mouth breathing, okay, is just muscle memory. The mouth stays open, the muscles stay open. So that is a way that we can do that. What category would palate expanders fall into? I have had several friends ask what the functional difference between a Crozat appliance and expanders is. Okay, so that's a good question too. Thank you. Expanders typically are just going to expand out laterally, okay? And there's certainly benefits to being able to do that. Now, the part that you could argue against as far as expanders go is you put in the expander, usually it's a fixed expander, so that means it's cemented in, okay? But it only goes laterally, just laterally, right? And you have a key that you've got to turn, and so you're forcing things laterally, okay? So you could make an argument that as far as from a craniosacral standpoint, you're forcing things, okay? Well, with Crozats or alpha appliances, we have the ability to go laterally and forward. And instead of forcing the body into a certain direction, we're just putting pressure on the body to kind of go like, this is where we would like you to go. If the body doesn't want to go, it will not go. Now, an expander will force it, okay? But a Crozat just puts pressure on it, light pressure in 3 dimensions. So that's the big difference, right? It's putting pressure instead of forcing, and it's going out in 3 dimensions. What one of my mentors had told me once, he's you cannot expand your way out of an airway problem. Now, expansion laterally is a good thing for sure. It is always good, but you also need forward development more so than you even need lateral development. So an expander just does lateral, okay? And the kids that I've seen get kids and adults that I've seen get expanders, I mean, the minimum distance that you want in between your first molars, your permanent molars, is 35 millimeters, okay? Most people, in my experience, from what I've seen, do not expand nearly enough, not even close. 35 is a minimum, okay? We'd ideally want that to be 40 or, even higher if we could get it. Now, again, that's going to be different in every child. Okay, those are just numbers that we use as kind of like guidelines. But we would ideally love to be able to get 42 millimeters in between the molars. Not every time can we do that, but 35 is a bare minimum. I've seen kids that have went through ortho, had expanders, that their intermolar width is 28. Okay, so we have to use expanders. And if you're going to use an expander on the top, or an expander or Crozat on the top, you're always going to need to do it on the bottom, because the bottom teeth, the top teeth is kind of like the lid on the box, right? So if you're not going to do anything with the bottom, you're going to be limited to what you can do on the top. You might be able to expand it a little bit, but you're not going to be able to expand it for very much, or else you're going to be in crossbite. Your teeth are going to go like this, okay? So if we're going to move out the top teeth, okay, you got to move out the bottom teeth too. But the Crozat offers, again, 3-dimensional changes instead of just 1-dimensional. Great question. I'll see here if we got any more. What brand of mouth tape recommends? Yeah. So there's a lot of different types of mouth tape out there. We usually recommend what's called paper tape. So it's a really cheap, inexpensive tape, and that usually works good for most people. That's what I use at home. The other mouth tape I think would work fine too. I mean, there is mouth tape out there that actually, I saw one brand that actually has a hole in there, which is, I guess does keep the lips together, but allows you to breathe out your mouth, which is kind of defeating the purpose to some degree, I think. But I'm sure most of these brands are still really good. If you find a brand that you really like, then certainly you can use it. But I just go with paper tape, 3M paper tape. You can buy it on Amazon really inexpensively. And it's cheap and easy to use. And it doesn't, again, I put it on my lips every single night. So, and McKenna just put a link on there. I use it on my skin every single night. My daughter uses it on her skin, my wife, and we do not have any residue, or you don't know that we've taped our lips at night. Okay. So, next question here. My son, who is 9, just got braces and an expander on his top teeth with an intent to create room for permanent teeth later on. I am now questioning if we're doing the wrong thing after watching this webinar. What would you suggest moving forward? Um, that is a great question. If you started treatment with somebody, I mean, without seeing your son, it's difficult for me to tell. If they're just doing expanders on the top and it's just a traditional expander, it's probably called the Hyrex expander. That's a really popular one. Again, you're just moving teeth laterally. Now, there is benefit to that, but three-dimensional changes are three-dimensionally better than just one-dimensional changes. And so I personally don't see the point of putting expanders on the top without expanding on the bottom. Somebody that has a deficient maxilla has got a deficient mandible as well too, most oftentimes. That's not 100%, but most oftentimes. So, I mean, there's obviously things you could do. You have the power to discontinue treatment. Certainly, you have that power. Then the next challenge is going to be to find an appropriate provider that is going to be able to give you what you want. I always tell patients of like, find somebody that's on your same wavelength. That's very important, I think, at least in my opinion. Find somebody that's on your same wavelength as far as got the same beliefs that you do generally in regards to health. Okay. If you seek traditional care, you're going to get traditional results. And again, I'm not saying traditional results is the wrong thing or a bad thing, but you just have to determine on if that's good enough for you. If traditional results are good enough for you, well, then great. I would seek traditional care. But if traditional results are not, then you're going to have to seek somebody that's non-traditional. And again, the reason why I put on this webinar is just because I go around every day, and again, I'm cursed by my knowledge of just the simple fact of looking at a person's face and being able to know what's going on generally in the mouth by just looking at their face and knowing like what could have been. And obviously my heart breaks for children because it's just like things could be changed if it was caught early enough. But in our current medical system and model, the goal is to be straight teeth. That's the number one focus. Cosmetics, which again I understand people want straight teeth. I want straight teeth too. I understand that. But cosmetics on my scale of importance is down here where health is way up here. And in traditional orthodontics, they talk about airway orthodontics, but then they put class 2 elastics, they put herpes appliances on, they do all these things that retract the teeth back, which is the complete opposite of health in my opinion. Okay, I'll wait another minute here, see if we got another question coming in. I appreciate the questions. This is probably my favorite part of doing this kind of stuff is just answering questions. I certainly like the the um, the interaction between people much better than on a computer, but I thought I would try this on the computer. I know certainly it is more convenient for people to kind of get on a computer and do this than travel somewhere. So I understand that as well too. But I do like the person-to-person contact a lot. So the question was, is it possible to schedule an appointment with you in Sturgis or you just in Gillette? No, yeah, we have availability in either location. If that is your desire, you could call the Sturgis office, or the Gillette office, whatever is more convenient for you, to schedule an appointment. I'd be happy to, certainly at least give you my opinion on things. Well, I'm glad somebody wrote, thank you. The retraction of teeth is what really caught my attention and was something I didn't know before. Yes, it is something that happens all the time in traditional orthodontics. That is the rule rather than the exception, is retraction, unfortunately, right? If you put a wire on the outside of the teeth and connect three-rooted teeth to single-rooted teeth, the three-rooted teeth are going to win, and it's going to pull things back. Well, I hope to, if we can get enough people that want to listen to something like this again, I'd be happy to do another one over the same topic, or more in depth on biologic dentistry, or health, or there's a number of different topics that we could do something in on. But I'm always happy to. I could get spread. I think what is very valuable and meaningful information to people that are wanting to get it. Will this recording be available after we are done? Okay, will this recording be available to share? You know what? Actually, great questions that I don't know the answer to. My IT person is in charge of this. We will try to make this available probably like, I think we have a private Facebook page, Facebook group page that we will put this on and make the whole thing available to. My IT people will probably be making maybe some small videos in relationship to that we'll probably use on social media. But there you go. McKenna said we are not sure. So as I said before, this is the first one, hopefully of many. I'd be happy to do many. Like I said, I like the in-person ones better, but I'll entertain the ideas, or kind of go in the direction that the people want most. We have another question here. I think I answered the question. I said, thank you. The retraction of teeth has really caught my attention, and that was something that I didn't know before. Yes, yeah. So that, as I said before, that is something that happens all the time in traditional orthodontics, unfortunately. And let's see here. Okay. Any other questions here? I'm just texting my daughter here. Okay. You're welcome. This is just thanks for offering this webinar. I would definitely be interested in future webinars. We truly appreciate everything you guys do. Hope you all have a happy Thanksgiving. Thank you very much, and you have a happy Thanksgiving as well. Okay, well, I will sign off here. Like I said before, I appreciate everybody who's come out tonight. Spread the word, is all I can say. This is really important information. All these things are preventable, so for the most part. And so if we spread the word, and the public is what's going to change the direction that healthcare has went, and it is going to go in the future. So if you can spread the word, that is great. If I can be of any help or use in your effort to do that, I'm always happy to participate and be a part of that. But thank you again for attending tonight, and all of you have a happy Thanksgiving, and a Merry Christmas.